These speakers don't work.
All right. Okay, so we have one last case. This is a 69-year-old who had an uncomplicated cataract surgery at one of our satellite clinics. He was hand motioned before his surgery. On post-op day 1, he was seen at our satellite clinic by his cataract surgeon, and it was a routine exam, 20/70, pressure 27. He then went back to his cataract surgeon on post-op day 3 for an urgent visit, complaining of vision loss and pain for a day. His vision was hand motion. IOP was 20. Exam was described as a shallow AC with fibrin across the pupil, notably no hypopyon, and a reportedly a B scan that was normal. So he was diagnosed with postoperative pupillary block. They performed a laser iridotomy in clinic, tried to re-deepen the AC with BSS in clinic, added cyclogel to his other postoperative drops, and was told to come to EUH through the ED, since this was over the weekend, for further management. The patient came, but didn't wait for a provider and left. So went back on Monday, back to his cataract surgeon, was still in pain, vision's hand motion, pressure of 10. The AC is flat with fibrin across the pupil. The PI is partially closed, still no hypopyon. And so the surgeon referred him to glaucoma at Emory. And so he presented to Dr. Beck's clinic the next day, referred for this pupillary block. Then he reports no pain, vision still hand motion, pressure is 12. And thanks for coming down, Dr. Beck. I know probably wouldn't be able to hear you otherwise. Just wanted to hear your thoughts when you saw this patient. What were you thinking? And, is postoperative pupillary block from cataract surgery something that is commonly seen?
No.
Right.
So one, the eye's inflamed. Okay, it's not normal to have a pupillary membrane, and you start thinking, what's causing so much inflammation? Infection's an obvious thing that goes across your mind. 2, the chamber is diffusely shallow. Pupillary block should be bowed up. You should see iris bombay. This chamber was diffusely shallow, not flat, but diffusely shallow. They tried a PI. And I talked to the cataract surgeon. He got through, and then they tried to deepen it. It was very difficult to deepen it. So then you start thinking, gosh, we've got 2 things going on here. And I started thinking about a malignant process, not that, even though we do have the fibrin across the pupil, not a standard pupillary block. And then what's going on in the vitreous? So you got to get a B scan.
Mm-hmm. Yeah, that's right.
Because you couldn't see, because there was enough fibrin that you couldn't really get a good idea.
Yeah, so use the UBM first. You see, I don't know if you can see my mouse, but the iris is up against the endothelium. Here's that membrane. And then all these opacities behind the iris, and the lens is here still in the bag. And like Dr. Beck said, your suspicion is high at this point. You want to, he said you want to get a B scan, and here it is. Another lesson for this is always repeat your own B scan, especially if you don't have a view. And here you see dense vitritis, vitreous membranes. And for the sake of time, I'll skip this. This postoperative endophthalmitis. And then what are the treatment options? So this is a very atypical case, and the treatment is atypical just because of how the patient presented. Usually what do? We like to do an AC tap for culture and inject intravitreal antibiotics. But at this time, there's no AC to, get any sample. So what's another option? We can tap the vitreous for culture, inject antibiotics, and this will also try to decompress the eye from all the fluid we're injecting. But the patient is not very compliant. He doesn't buy into this. He doesn't want to do this procedure. Vitreous taps also come with a higher risk for retinal tear and detachment, higher possibility of a dry tap. And then in that case, if we were to inject antibiotics of volume that was more than we took out, increasing the volume could further precipitate the ankle closure. The ideal situation with his presentation is to go to the OR, reform the AC, do a diagnostic bit, take the sample from there, and inject antibiotics. Doing the diagnostic bit also decompresses the eye, gives you room to put in the antibiotics. But so the patient at this point, he's not in pain. There's no hypopia on exam. It's been 5 days since the onset of his symptoms. He's not NPO. It's late afternoon and we can't go to the ASC. So the option would be for him to stay until he's NPO long enough to do it at the main OR, but he didn't want to do that. And so, oh, Dr. Ye raised his hand. Sorry.
I can let him talk. We just won't be able to hear him. You can feel free to talk. Unfortunately, that's an auditorium. I can't hear you. So
you hear me?
Something.
yeah, if you want to type it in instead, I'll be happy to read it. I'm sorry.
Are you able to hear me?
Do this case with him the next day. So the plan in clinic when we saw him was to reform the AC, do the diagnostic, inject the antibiotics the next day. But at that time in clinic, we started him on oral antibiotics. So moxifloxacin, 400 milligrams, has good vitreous penetration, and usually what we use for oral antibiotics in endophthalmitis. And then we changed him from ofloxacin to moxie, had him use it Q1 hour while he's awake, and continue the other drops. Next is the video. I don't know, does Dr. Yan, do you want to make any comments at this point?
Well, I think you've done an excellent job summarizing the care because, you know, after Dr. Beck saw him that day, he came to my clinic. So that was quite a dilemma treatment-wise. And honestly, I would say for the last 15 years of my practice, 16 years, I have not seen that endophthalmitis presenting like this. I don't know, Phaedra, have you seen anybody presenting like this?
You don't want to talk to yourself?
No, you can show it is.
No, I haven't seen a case like this. It's very unusual.
Mhm.
Very challenging in terms of treatment because we know the standard of care is to immediately tap and inject. But in the case of this patient that we just weren't, you know, we couldn't do it.
Yeah.
So Dr. Ye,
Yeah, I would just comment that it was a really fluid. I think Alan, that was a great call about. I mean, there was something odd going on. We're concerned about the possibility of infection, but ultimately with the iris plastered against the cornea, the main concern is that if you go in and do a tap and inject in the clinic and then you precipitate a worse situation because you have a dry tap or whatever, patient's uncomfortable, you need to take them to the OR anyway. You're better off going to the OR. And then I don't remember the timing, but I do remember that there were a lot of logistical constraints, like related to just main hospital delays because of just how busy the hospital was at the time. But that being said, it just wasn't logistically going to be possible to bring the OR. The other thing to take into consideration is that he had kind of an indolent presentation. So the question is whether this is really a severe inflammatory response. It was a 5-day history, and then most of the time the outcome was predicated on the organism. If it's a staph, you're going to be okay. If it's a strep, then the eye's probably not going to do well. But ultimately, our decision was to take him to the OR in a very controlled situation. So,
and part of that is the patient too. He was not a very compliant patient, so.
he did not want to stay.
Yeah.
He's a very interesting guy. Just so everybody knows, this was not a good eye for him. This was an eye that had relatively poor vision. I think is amblyopic.
Mm-hmm.
And then it kind of went downhill. He had a pretty poor experience in the ER. We got to remember there are other patients in the emergency room. We are in a pandemic, and that was a huge.
Yes.
It was a huge. Did not get seen, and he waited several hours in the emergency room. Then they contacted us, but there was some lag, and he was like, "Okay, I'm not hurting that bad. I'm just going to go home."
Right.
So when we started talking to him about going to the hospital again, it was like, no,
He wasn't.
he didn't want to say. That backstory is helpful. He's not crazy. He just, this is not a good eye. He wants him to be comfortable. He'd like to see some, but it's not a 20/20 eye. Everybody knows.
Yeah.
So his perspective was a little different, perhaps, than ours.
Let me just play this video real quick. So
And he wasn't in pain when he presented.
Right.
that to us.
That's the other key. So the really difficult to enter into the chamber. We deepen it and then made a second paracentesis here, much easier. So this is all this pupillary membrane, this grayish shadow here, trying to use visco to create a plane between the pupil and the fibrin, and you see that we just can't get through it. I'll try to skip through this. So we decide to put in the trocars at this point. Here's the NBR blade that we use to really create that opening. And finally get through and slice that open. And see, it's really sticky. And then if you watch here, you'll see some like white fluffy material that starts coming up from under the iris into the AC.
And so for the residents and the fellows, like whenever if you're doing a case and you see this fibrinous membrane, I mean, oftentimes you do see this in endophthalmitis. And so the people will be really small. It can be difficult to get through. And then so you have to just kind of work through and then pull out it's a big, thick membrane actually on the IOL.
Yeah.
This is all Dr. Zhu's nice work. So
I
she gets all the
agree.
credit.
I was there watching the surgery. This could potentially be a very, very complicated case. And I mean, Dr. Lucy, you really did a fantastic job. You made it look easy.
Thanks. So this is max scripts that we're peeling the membrane off. And then you'll see here how adherent it is to the pupil, because when we're pulling, all of that black is the iris pigment epithelium that gets reflected because it's so adherent.
And so also for the anterior segment surgeons for any membranes, so there's two retinal forceps that are pretty useful. One is the max grip, but the tips are a little small. I just recently discovered another forceps that's a serrated 23 gauge forceps that actually gets a little bit better purchase. So if you've got membranes that you need to remove, or somebody with a glaucoma or cataract intervention, sometimes with these uveitis, it can be helpful.
So here the view is much improved. We're just doing a sample now from the cutter to send for a specimen. And then here's the view inside the eye. And you see all these vitreous membranes connecting up here. And the goal of this surgery in endophthalmitis is to, do as little as you can and get out of the eye. So, the pupil's small, which is why the view comes and goes. We don't want to put in iris hooks. There's no need to go out in the periphery and shave the vitreous and do any sort of fancy stuff. Just trying to get all of this decompressed. You see this white, fluffy pre-retinal lesion here.
And I like to get a view of the retina to see if there's any sclerotic vessels or obvious retinal whitening to kind of get a feel for the prognosis in terms of how the patient's going to do. But just like Lucy said, I mean, I just like to core out the vitreous, do a little mid peripheral vitreous dissection, and then not make any breaks. And inject antibiotics, and then get a view.
And that's the key.
That's generally just because I know I can get in trouble if I'm in the eye too long.
So we do PI with the cutter. Here it's open, and then there's still debris that's coming out through the PI here. Clean that up with the cutter. I'm not going to show the rest of the video, but we take out the trocars, and then the most important thing at the end, we inject the antibiotics. Vancomycin has. So
one thing Dr. Brooker had put in the comments as far as, obviously he said, seen this at least sometimes at Grady, but one way to kind of get around it, it doesn't sound like this patient would have been a patient you could do this on, but transfixing the iris and obtain fluid kind of from the sulcus there, especially after that UVM, I guess. And then the other thing he says, he's had some success with TPA injection into the AC to help with the fibrinoid reaction as well. So again, it doesn't sound like this patient would have gone for those things, but it's an option.
If we did it early enough, possibly, but at this point, just remember, you saw how fibrotic it was. I don't think you're going to resolve it with TPA, but if you could have gotten in there perhaps this weekend, but then you got to get, the TPAs can be challenging, but but
Alan, do you use TPA for any glaucoma?
we haven't in a long time. We used to try it at times in very inflamed eyes. And we can do something, but you got to get in early, and sometimes you have to repeat it. And it can help, but early, once you get this thick membrane, wow. That's what I thought you were gonna. I actually was thinking about trying to reopen the LI and seeing if I could tap the anterior vitreous. And I looked at that piece and there's no way am I trying that.
Right. But you know, the sample did end up growing gram-positive cocci on the gram stain. There was no growth in culture, but you know, we did put him on PO antibiotics before we got this. So this was, you know, endophthalmitis. And then the key points, you know, for this case, always be suspicious of post-op endophthalmitis, even if there's something atypical in how it presents. Any patient with signs of inflammation, you need to think about that. Timely administration of antibiotics is key, but we got to balance that with risk of causing further damage. And, you know, the patient's got to buy into what you're planning on doing. So, all right, that's all I have. Thank you.
All right, thank you very much.
Good job.
Thanks.
The resident lecture to follow will start about 9:15. I'm going to try to figure out the volume issue in the meantime. Thank you, everybody. Sorry for the technical difficulties.
So Jeremy, so people can talk on the chat.
They can talk on the chat.
Right.
The issue.
Well,
Yes.
yes.